Good afternoon, class. I'm sorry I won't be able to be here with you today. I have an earlier engagement that I need to attend to. But anyway, we will still continue to discuss cardiovascular system today, and hopefully we can finish this today. And remember, whatever we discuss today will be part of your test on Tuesday next week. And don't worry, my alter ego, Mr. Steed, will be joining us or joining you today, and he will be assisting you with any questions that you may have. So anyway, so I remember last time, Tuesday, we were discussing cardiovascular system, and this is the part where we stopped, and we were talking about common signs and symptoms associated with peripheral vascular diseases. So now let's talk about the common signs and symptoms associated with cardiovascular disorders. If a patient came in to the emergency room and the patient is having cardiovascular diseases, what are the most common complaints that the patient will probably present? And what are the most common complaints that you may elicit from the patient by interviewing the patient or by asking using doing your health history. So the most common complaints of a patient having cardiovascular disorders will be chest pain, shortness of breath, of course fatigue, palpitations, dizziness or syncope or fainting, diaphoresis, edema, and of course weight gain. So if the patient is having some problem with ejecting blood towards the aorta and there is an increased preload secondary to increased afterload, then all of these will be presented, or some of these will be presented by the patient upon admission in the emergency room. So let's dissect this one by one. Chest pain. If a patient is having cardiovascular diseases, one of the most common complaints will be chest pain. And chest pain is usually associated with decreased oxygen supply to the myocardial muscle. So if you have coronary artery disease and there's a decreased blood supply to a certain portion of the heart or of the heart muscle because of atheroma or atherosclerosis, then that chest pain could cause a lot of problems. Alright, so what are the most common types of chest pain and their underlying causes? Now, remember that chest pain is usually due to decreased coronary tissue perfusion or compression and irritation of the nerve endings. And we've talked about this several times. A decreased oxygen supply to the myocardial muscle or to the muscle of the heart will cause, if there's a decreased oxygen supply to the myocardium, then what will happen to the cells? Again, the cells will be forced to shift from aerobic to anaerobic metabolism, yielding a lot of lactic acid. And since these are lactic acids, it can cause irritation of the cells, it can cause irritation of the nerve endings. And that's when the patient will complain of chest pain. So, some of the most common chest pain that you may elicit from the patient will be sharp, severe substernal pain or pain to the left of the sternum, may be felt in epigastrium, referred to the neck, usually relieved by sitting upright and medications such as anti-inflammatory medication, especially right here. Most likely, you're dealing with a condition called pericarditis, and if you have pericarditis, the pericardium or the pericardial sac is inflamed due to some infection. And remember, that can lead to accumulation of fluid in the pericardial sac. That can lead to cardiac tamponade. So we want to know whether the chest pain of the patient is due to decreased coronary tissue perfusion or it's just something about inflammatory condition of the pericardial muscle or a pericardial sac, I mean. If the patient complains of substernal or retrosternal pain, right behind the sternum, right here, spreading across the chest, right here, It may radiate to the arms, neck, or the jaw, especially to the left arm, left neck, and left jaw. With 5 to 15 minutes interval, usually related to the 4 E's. Remember the 4 E's that may trigger angina pectoris. Right? Angina pectoris can be triggered by, first, exertion. Any type of exertion will cause increased oxygen consumption. And you know, increased oxygen consumption will lead to increased oxygen demand and increased workload of the heart. And if the patient has coronary artery disease, the patient has decreased tissue perfusion in the myocardial muscle, and the patient was engaged in an activity that causes an increased oxygen consumption, then it can lead to chest pain. Another E that can trigger angina pectoris will be emotions. Why emotions? Remember, sympathetic nervous system. If the sympathetic nervous system is stimulated, the main effect of stimulation of sympathetic nervous system will be constriction of the blood vessels. Sorry. Constriction of the blood vessels. So, if you constrict the blood vessels, then what will happen to your afterload? Afterload will increase, right? So, if you have an increased afterload, again, the heart will be pumping against greater resistance, and that will again cause an increased workload for the heart. An increased workload for the heart will mean an increased oxygen consumption, an increased oxygen demand. That can lead to chest pain because of decreased myocardial tissue perfusion. Another is eating. Well, not just eating, but overeating. So if you eat a lot, then what will happen? Aside from the fact that your tummy will get big, and a big tummy usually impedes on the respiratory function, because if you have big tummy, then what will happen to the muscle of the diaphragm? The muscle of the diaphragm won't be able to descend fully, and you won't have full expansion of the lungs. Now in that way, you're not getting enough oxygen, so you will have a problem with the exchange of gases. And aside from that, if you overeat, then what will happen to the body? The body will try to concentrate all the oxygen to the digestive tract, because the body needs to digest the food that you ate. So if you ate a lot, then most oxygen will be concentrated to the digestive tract and leaving the myocardial tissue, again, less oxygen, and that can cause chest pain. Okay? Another is cold weather. Well, Mr. Verdad, that's not E. Well, let's put exposure to cold weather, right? So, exposure to cold weather will cause constriction of the blood vessels. Any condition that will cause vasoconstriction will cause an increased afterload that will not be beneficial for the heart, because that means an increased workload for the heart, and an increased workload will mean an increased oxygen consumption and an increased oxygen demand. So all of these 4 E's: exertion, emotion, overeating, and exposure to cold environment will trigger angina pectoris attack or chest pain caused by angina pectoris if the patient already has a pre-existing coronary artery disease. Right? So most of these, if it is indeed an angina pectoris, normally it should be relieved by rest, by nitroglycerin, and by oxygen. But remember, we had that nitroglycerin test. We can only give 3 doses of nitroglycerin sublingual, 0.4 milligram, at 5 minutes interval. If the patient is still complaining of chest pain for more than 15 minutes right here, hold the nitroglycerin. Most likely, you're already dealing with necrotic myocardial tissue, and that means that you're already dealing with a myocardial infarction. Okay. Next. If the client is complaining of substernal or pain over the precordium right here, may spread widely throughout the chest, painful disability in shoulders and hands, lasting for more than 15 minutes, most likely you're dealing with acute myocardial infarction, especially if the pain persists despite of nitroglycerin. And the only way you can address the pain of the patient is by giving morphine sulfate. Remember our acronym, MONA, right? Morphine, oxygen, nitroglycerin, and aspirin. But remember, because, um, common sense will tell you, what will I give first to the patient? Will I give the oxygen the morphine first before the oxygen? Because that's what MONA stands for. But in reality, you can easily administer oxygen inhalation by nasal cannula. You can give that even before giving the morphine sulfate. So even if it says MONA, you will still give the oxygen first because that's easier. We can do that without any doctor's order, especially if you will only give 2 liters per minute. Um, if the patient is complaining of substernal pain projected around the chest or shoulder, 5 to 60 minutes spontaneous, relieved by food antacid or nitroglycerin. Sometimes it can be a symptom of hiatal hernia, GERD, reflux esophagitis, or esophageal pain. Pain arising from inferior portion of the pleura, right here, may be referred to causal margins or upper abdomen, can be located by the patient, 30 minutes or more, relieved by rest, time, and bronchodilators. Most likely you're dealing with inflammation of the pleural cavity or the pleural space. Well, not the space, the tissue. And you might be having pleuritis that can lead to, pleural friction rubs. So if the patient is having this type of pain right here, from inferior portion of the pleura right here, then most likely you're dealing with pleuritic pain. Pain over the chest may be variable, does not radiate. 2 to 3 minutes, occurs with stress, emotional tachypnea. Patient may complain of numbness or tingling of the hands and mouth, especially if the patient is breathing too fast. If you have extreme anxiety, husband, it's already 3 o'clock in the morning, husband hasn't come home yet, the cell phone is off, that could cause some kind of chest pain, right? So what will you do? Say, removal of stimulus, relaxation technique. Just relax. You remove the stimulus. If the husband is the one causing you anxiety, get rid of the husband. I'm just kidding. Alright. Dyspnea. Another signs and symptoms associated with cardiovascular diseases, of course, shortness of breath, right? And we have several types of dyspnea. We have exertional dyspnea or dyspnea on exertion. This is one of the most common type of dyspnea because remember, exertion again will cause an increased oxygen consumption, and an increased oxygen consumption will mean increased oxygen demand by the cells. It occurs with physical exertion, relieved by rest, occurs when the body uses more oxygen, makes more carbon dioxide during exercise or any type of physical activity. This may indicate decreased cardiac reserve because your patient is consuming a lot of oxygen, right? Another type of dyspnea, and I believe we already talked about this in respiratory disorder, paroxysmal nocturnal dyspnea, or PND. This is shortness of breath with sudden onset. It occurs usually during sleep at night. The patient will just awaken with feelings of suffocation. Patient will be gasping for air, and they will feel like they're drowning. This will be relieved by sitting up. A lot of times, this is associated with congestive heart failure, particularly left-sided heart failure. Okay. Alright, orthopnea is shortness of breath in reclining lying position, relieved by sitting up. It's usually associated also with congestive heart failure, left-sided, or even COPD. And remember, these are, you probably notice some of your patients won't be able to sleep without asking for 3, 4, 5 pillows at night. Yeah. Another signs and symptoms common among patients with cardiovascular disease is fatigue. Well, fatigue is a consequence of inadequate cardiac output. If there is inadequate cardiac output, such as in the case of left-sided heart failure or acute myocardial infarction or cardiomyopathy, then what will happen? The contraction of the heart will be less effective and weak. And so it will cause less stroke volume, and less stroke volume will ultimately lead to less cardiac output. Any decrease in cardiac output will mean decreased oxygen supply to the different parts of the body, particularly the major organs of the body. And the cells will be deprived of much needed oxygen also for their metabolism. And so if the cells cannot produce adenosine triphosphate, remember, that's the energy of the cells, right? And without oxygen, the cells won't be able to produce adequate ATP. They can burn their fats, it will yield lactic acid, but it will not be enough, okay? So if there is an increased oxygen demand and there is decreased oxygen supply due to decreased cardiac output, then obviously, because of decreased adenosine triphosphate production, patient will have fatigue. Palpitations. Palpitations is the unpleasant awareness of the heartbeat, described as pounding, racing, or skipping. It occurs during mild exertion. It may indicate heart failure, anemia, or thyrotoxicosis. So what does it mean? Patients who are having, let's say for example, anemia. Anemia means you have less hemoglobin count, and therefore if you have less the hemoglobin count, your blood has less capability to carry the much needed oxygen for cellular metabolism. So what will happen is, if you have anemia, the compensatory mechanism of the heart is to increase the heart rate so that it can supply more blood to the cells, and hopefully by doing that, it can give, adequate amount of oxygen. But by doing that, by increasing the heart rate secondary to that compensatory mechanism, then the patient will have that kind of palpitation. Thyrotoxicosis, what is thyrotoxicosis? Thyrotoxicosis is actually a bad form of hyperthyroidism. If you have hyperthyroidism, and what is hyperthyroidism? That's a condition wherein your thyroid gland is producing too much T3 and T4, and the cells are producing too much, ATP, and that can cause an increased basal metabolic rate, increasing your everything. Your heart rate will increase, your pulse rate will increase, blood pressure will increase. So patient will have palpitation as well. And of course in heart failure. Why? Because if there is a heart failure, decreased cardiac output, initially the heart will try to compensate. Remember, the all or none law principle. What else? Dizziness or syncope. Dizziness or syncope is characterized by generalized body weakness with an inability to stand upright, followed by loss of consciousness. And again, this is due to decreased cerebral tissue perfusion. If there is decreased cardiac output secondary to whatever cardiac disorder the patient may have, then what will happen? Decreased cardiac output will be tantamount to decreased supply of oxygen and blood and other necessary nutrients to major organs of the body, particularly the brain. So if the brain is not being perfused properly, so if the brain tissue is being hypoperfused, then it may alter the level of consciousness of the patient, or the function of the central nervous system will be altered, particularly the level of consciousness. And remember, the level of consciousness is the most sensitive indicator of decreased tissue perfusion in the brain. And I hope you know how to assess those level of consciousness, right? If the patient is alert-oriented, lethargic, stuporous, semi-comatose, and comatose. We'll talk about that in neuro, but just kind of remember that. Edema. Edema is due to increased hydrostatic pressure in the venous system, resulting to fluid shift from intravascular compartment to interstitial compartment, or intravascular fluid to interstitial fluid. In case of congestive heart failure, which of the two types of congestive heart failure will most likely lead to peripheral edema? Will it be the left left-sided heart failure or the right-sided heart failure. If you're familiar, if you know the flow of blood, all you have to do is remember how the blood flows to your heart, right? So if I have a problem with my left ventricle, then what will happen is, if the left ventricle is weak, in case of left-sided heart failure, then less amount of blood will be ejected towards the aorta. More blood will be retained in the left ventricle, because instead of having good contraction and strong contraction, you will have weak contraction, leading to decreased cardiac output but increased preload. And so time will come that increased preload, every time that the heart contracts, less amount of blood will be ejected towards the aorta, more blood will be retained in the ventricle, in the left ventricle, and so your preload will increase every time, and it will regurgitate back, or it will back up to the left atrium and then to the lungs, causing your pulmonary edema. Now in the case of right-sided heart failure, if the right side of the heart is weak in contraction or in contracting, then more blood will be retained in the right ventricle, and time will come that blood will back up to the right atrium, back up to the superior vena cava, and you will see distended jugular veins. It will back up to the inferior vena cava, causing ascites, hepatomegaly, and this peripheral edema. So peripheral edema is usually associated with right-sided heart failure, and pulmonary congestion or pulmonary edema is usually associated with left-sided heart failure. But whether it's left-sided heart failure or right-sided heart failure, remember the bottom line is you have a decreased cardiac output, and a decreased cardiac output will mean decreased oxygen supply to the vital organs. So, past medical history. Why do we need to assess this, and why do we need to ask this history from the patient? Well, remember, and we talked about this last time, there is a microorganism that has high affinity to the valves of the heart, and they also have high affinity to the glomeruli of the kidneys. And this group A beta hemolytic streptococcus is very, very important in assessing potential or possible heart problems or heart abnormalities. A patient is complaining of some chest pain and having some cardiovascular symptoms, right? So it's important to ask those childhood and infectious diseases, previous illnesses and hospitalizations, and of course the medications that the patients are taking at home. Alright, and then we have to talk about risk factors. We can ask the patient about things that may give us information whether the patient is at high risk for developing cardiovascular disease or not, right? So, risk factors are actually divided into two major categories: the non-modifiable risk factors and the modifiable risk factors. Difference? Of course, non-modifiable, you cannot do anything about it. Modifiable, then that's something you can control. Alright, so let's talk about non-modifiable risk factors first. What are the things that can make a person susceptible to cardiovascular diseases, right? But we cannot do anything about it. So far, right now, there is nothing that we can do about this. Number one, age. If you're above 40 years old, well, congratulations, because you just increased your chance of getting cardiovascular diseases. I mean, you cannot modify your age. You can lie about it, but you cannot modify your age, right? 40, above 40, that's what? The over the hump, over the hill, whatever type of birthday you have, this is one of your birthday gift. Aside from your visual acuity, you will have, you will be more susceptible to cardiovascular disease, right? If you have a family history of cardiovascular disease, you cannot deny your family members or your family. I know some of us don't like some of our family, but you cannot modify that. You know? No. But heredity plays an important factor in making the patient susceptible or at high risk for developing cardiovascular disease. If your parents had cardiovascular disease or has cardiovascular disease, if your uncle, your aunt, and your grandparents, if it runs in the family, then you have the 50% chance of developing the same disorder, unless you do, you can delay it, but the risk is there. You're at high risk. The race. Well, here's the thing. African Americans are more susceptible to cardiovascular diseases compared to Caucasians. Right? We know that based on statistics, cardiovascular diseases ischemic heart disease is still the #1 cause of death all over the world. And again, like I said, African Americans have higher risks of contracting or developing cardiovascular diseases compared to Caucasians. Asians were more susceptible to vehicular accidents. You know why. Gender. Gender. We cannot change that, right? Unless you're chasuble, no? If you know chasuble, no? Well, males are more susceptible to cardiovascular disease before the age of 65 years old. So, before the age of 65, we are more susceptible, especially if we're above 40. Females, after 65 years old, the odds are even. Why? Because females, you have the estrogen and progesterone that kind of helps you distribute your fats all over the body. That's why, those estrogen, that's why a lot of ladies right now, a lot of women, after their menopause, they will still continue to have HRT or hormonal replacement therapy, not because they want their skin to be still nice looking and their hair and their beauty, but it's more of the internal health of their organs, particularly the heart and of course the bones as well. So hormonal therapy is very, very helpful for these women, but we cannot change the gender. All right. If you're born a male, you're a male. If you were born a female, then you're a female. Right? You can have several surgeries, if you have money, but you are still wired like that. So again, and I don't know if you notice this, among elderly couples, usually the male will go first before the female. I don't know why. Maybe he got tired. Anyway, so these are the things that you cannot modify: the age, the gender, heredity, and the race. Right? How about modifiable risk factors? These are the things that we can control and we can modify, so that if we can control these, then we can somehow decrease the susceptibility and our risk of developing cardiovascular disease. One of the modifiable risk factors, that are known to contribute to the development of cardiovascular disease will be stress. Why stress? Well, we said stress usually causes activation of the sympathetic nervous system. And activation of the sympathetic nervous system will cause release of catecholamines, epinephrine, and norepinephrine. And this will cause vasoconstriction